wait for Vivek Verma to join us, and then we'll start.
Yes, Pratik. Good evening.
Good evening, sir.
Yes, good evening, guys. Jamie,
Good evening, sir.
Yes, sir. Good evening, sir.
And all the new ones whom I don't know. Where is our moderator? Operating, I guess.
He's joining. He just said he's joining.
Okay. So all the delegates and faculty are together in this entire year, or the delegates have a separate year list?
Sir, together.
Together, no?
Yes, sir.
1, 2, 3, 5. Okay.
So Dr. Vivek is having slight difficulties in logging in, so we'll just wait for him for 2 minutes, and then we'll start.
Of course. He's the boss of the day.
Yes, sir.
We can't start without him.
Dr. Vivek, if you can hear us and if you can start the proceedings, that would be great.
I think he has joined, but his mic is not working.
Dr. Deepak, Dr. Jamin, Dr. Lokesh, Srimant. Divesh is not there. I think we'll just follow up Divesh.
Hi, Vivek.
Hi, hello Jamin bhai.
Hi, all well.
Hello.
Sir, तो start कर लेते हैं. It's
Yes,
5.
I think let's
It's
start.
5:30. Yeah.
Just 1.5 hours.
Yeah.
And we have a lot to cover.
Yes.
So shall I give the introduction then? Because I'm supposed to introduce.
Yes,
today
sir. Yes, sir. Yes, sir. Please
as
go
per
ahead.
the program.
Yeah.
So thank you everybody for joining today. This is the 4th in this web series, academic web series of Sarcoma Education Foundation's Nurture the Future program. I think today's topic is on management of non-GCT benign bone tumors. I mean, GCT itself is a topic which deserves a lot of time. So I guess that's why it has been separated out from here. But besides giant cell tumor, we have a lot of benign conditions which deserve our attention, and some of them also need management. So today we have selected few of the common diseases that we get to see in our practice, and they will be covered in detail by the eminent faculty. And all these topics will be open for discussion since we are a very small group. So anybody who has any queries can, put that in the chat box or even discuss with us. But I guess We will let the presenter complete their presentation and then, discuss it out. What do you say, Vivek? Vivek?
I think there are some issues with Vivek sir's.
No problem. No problem.
Yeah. But yeah, agree, sir. Yeah.
Yeah, let's just start. Srimant, please come over and, the Zoom platform is yours.
Thank you, sir. I had actually shared a small recorded presentation. Can I request Pratik to just play it, please?
Yes, we'll share that presentation now.
Thank you, Pratik. I'll be online. Greetings. I'll be talking about the principles of management of benign bone tumors. So why do we need to talk about these benign bone tumors or any sort of tumors? Because these are rare. Having a path or having a flow chart will help you come down to the right diagnosis and the right treatment. So what does this include? Right from clinical basis to staging to surgical treatments or any other alternative treatments. How do we do this? It's by a simple approach, right from history to imaging to biopsy to staging, discussion, and a treatment option. So what are the main features in the history? It's mainly pain or tenderness or a swelling. What are the less common signs? Constitutional symptoms which are rarely seen in benign bone tumors but can be seen in metastasis and sarcomas. When we do a physical examination, we always try to retain the basics of mass, tenderness, joint, above and below, the volume, and also the neovascular status. If there is deformity and instability, they're often for path fractures or fragility issues with the lesion when it's totally expanded. So one needs to be careful about examination. In imaging, basics is always first. We go for the X-ray, the tube use involving both the joint ends, and we often do the MRI. Ultrasound and CT usage is much less nowadays. So what do you do when you do an X-ray? What are the questions you ask yourself to find out, to reach the diagnosis? Where is the lesion? What is the extent of the lesion or the size of the lesion? What is the bone doing to the lesion? What is the lesion doing to the bone? And is there any clue about the matrix? When you do an MRI, which is the most common entity, and 1.5 Tesla with a contrast is a standard, which is advisable. We always try to see the extent, the matrix, the necrosis, if there's any neovascular status, and also skip lesions, which are more common in sarcomas and less common in benign bone tumors. CT scan, the utility is limited, but I've just put a reference to the slide. Laboratory monitors, definitely yes, we do the basic blood tests and always try to do an alkaline phosphatase or hyperthyroidism profile with a PTH to ensure that you rule out for any light lesion. Would you do an FNAC or biopsy? Biopsy is the gold standard. How do you do it and who does it? Usually the surgeon does it or it is under guidance. There are a lot of principles to take care, and this will be covered in different chapters or different sessions. And as I said, this flowchart would help you try to get the right tissue or the good amount of tissue which is representative to ensure that you get the good diagnosis and treat the patient. Staging, this slide is a mistake or a misnomer. Why? We have seen a lot of patients coming down on CT scan after a benign bone lesion or even a PET CT scan. I would reiterate that a simple X-ray is required or enough in case for giant cell tumor, which has a chance to metastasize very rarely, especially in the distal radius, or in certain recurrent conditions or when we're suspecting malignant transformation, any of these images can be done. But routinely, a simple chest X-ray itself is more than enough for any sort of lesion. And what do we do once we do these tests? We try to do a tumor board discussion. Do we need a tumor board for a benign bone tumor? Definitely yes. It would always make sure that it strengthens your treatment plan and it helps you communicate with the patient and do the best treatment. So how do we treat them? Please don't treat these. Don't even do anything. Master inactivity. But if you do operate, always biopsy followed by a plethora of options, right? From minimally invasive to maximally invasive or extensively extensive, and even chemotherapy options, which are in the form of benzimab and zoledronic acid, which has been used for quite a few light lesions. So a simple example of a simple bone cyst in a proximal tumors treated with decompression and interleukin steroid, and the way these things to heal. Radiofrequency ablation is another good tool which we have used. We can use for osteostomas, we use for chondroblastomas, which can be used in any sort of situation. And we've even got a more alternative option, which is cost-effective, which is CT guided drilling of the nidus. But one has to be careful that this can be a component alone, or this could be a component of RFA also. Spinal lesions can also be treated by such surgeries, making sure that they're away from the epidural space. What else would you do if you get an aneurysmal bone cyst? The treatment options also like similar, from minimally invasive to the maximally extensive. In the situation, we have done a chiropsy and a percutaneous sclerotherapy repeatedly, and the child is healed. Similar situations wherein a aspect granuloma was found, we do a minimal invasive procedure. A biopsy itself can cure it most of the time. Sometimes we do an intralesional steroid. A chondroblastoma, as I've shown or said before, is treated by radiofrequency ablation. So we've had the conservative one, we've had the minimal invasive one. Now comes the real role of the surgeon. Yes, surgeons are not jobless. We have surgeries to do, but how do you do that? Patient selection is crucial. Why? Because we have to balance the efficiency of local recurrence reduction versus regaining functional ability. How is this done? By ensuring we get the maximum disease clearance and we do the appropriate reconstruction. Example of an extended curettage and a bone grafting, and also an osteotomy correction in a young boy with an aneurysmal bone cyst. An example of a giant cell tumor treated with a composite reconstruction, which was a aliacrus graft, cement, and a plating technique. Sometimes, such recurrent tumors need to be resected, and we do a biological reconstruction, which is an ulnar translocation. Some situations may require a tumor process, such as this proximal tibia and this distal femur. So pathological fractures, non-pathological fractures usually are the indications or less bone stock for tumor process reconstructions and weight-bearing areas. And yes, salvage for the salvage is also done, and we have a lot of options of reconstructions once we do a good clearance. What about pelvis? If you look at benign lesions, definitely we have a good role for non-operative or medical management along with surgical management. Denosumab and zoledronic acid has given us a good role to play. And in this situation, this patient underwent both intralesional curettage, a resection, or a partial internal epilectomy, and also a denosumab injection to ensure that he is disease-free and function well. But certain situations, the surgeon has to take a step back and ensure that there is a limit to, trying to operate or limiting the mobility in this scenario. And denosumab with embolization serially has done a wonderful job in limiting these sort of situations and even controlling the disease. But beware of malignant transformation in very less cases. So what do you take home from here? Always have a high index of clinical suspicion. Never ever assume that every lesion is benign just because you look at the X-ray or the MRI. Don't have any shortcuts. Go by the protocol. Have a multidisciplinary team. Communicate, because that is where you can select the patient and your success depends. Thank you.
So thank you, Srimant. That was quite crisp presentation about the management principles in benign bone tumors. So is there any question? So, okay. I will ask one question. What is the classification generally that we follow when we are planning for any treatment in benign bone tumors?
Yeah, thanks, Vivek. I am audible, right?
Yeah, you are audible.
Hello.
Yes, you are audible.
There's a bit of a network lag. I'm sorry about that. So I missed that slide in the presentation. So whenever we try to
I think your internet has some issues.
was a call drop. Am I audible now?
Yes, you are.
Yeah. So reiterating again, I missed that slide in the presentation, and it's a very valid one. Whenever we look at any benign lesion on the X-ray, we try to see whether it is a totally latent one, or I would say initially to start with an inactive one, that is a type 1, or a latent one, or whether it could be an aggressive lesion. The way we try to find out about this on the X-ray is by the way the lesion has a sclerotic wall. That itself is an indication for us to know the activity of the lesion. And as I said, most of the lesions which we are discussing today often tend to have something like a good sclerotic limb or a thin sclerotic limb. Whereas the giant cell tumor, which is not on topic today, tends to go into the category 3, which often tends to be an expansor lesion along with an aneurysmal bone cyst with a very thin sclerotic limb, or maybe no limb also.
Right. And also the WHO classification is no more just between a benign and malignant lesion. So there is an intermediate grade, because some of the benign tumors which shows metastasis like giant cell tumors or chondroblastoma. So there was always a doubt where do we place them? Is it a purely benign or malignant? Because they are showing some sort of intermediate behavior. So I think in 2013, WHO classified into an intermediate grade between a locally aggressive and rarely metastasizing one. So this is also one way of looking at it. And you rightly said, and even the same histology, say simple bone cyst, it may fall into latent also, it may fall into active also, and it may fall into aggressive also. So it depends upon the biology of the behavior of the tumor, how it is behaving, and depending upon the radiological response, the NA classified them into latent, active, and aggressive. Fine. So
yeah. May I put a point here, Vivek?
Yes,
as
sure,
you rightly
please.
said, in our clinical practice, we don't stick to one sort of classification or a type, right? As you said, it's a spectrum.
Yes.
A chondroblastoma, a long-standing one, could have been burnt out, or an osteoblastoma could have got burnt out. So it will turn from something latent to a totally benign one. So I would say the utility of the classification in practice is limited. What we need to look at is try to correlate the symptoms, the radiology, and the pathology, all three together, to find out whether we're really dealing with an active disease or not, and base our treatment on the three findings together.
Absolutely. Absolutely. So do we have any more comments? I think this was very well summarized. Chetan sir, any points from your side?
No, I think you all covered it really well. Yeah. Let's move on.
Fine, sir. So I think the next talk is mine only, which is on the simple bone cyst. So I'll just share my screen. My screen is visible?
Yes.
Yes, it's visible.
Yes, sir. Just a second. My slides are visible?
Now it's visible.
Right. So fine. So today I'm going to speak on a simple topic, which is the simple bone cyst. Simple bone cyst, I think, as an orthopedic surgeon, we deal with it in our day-to-day practice. And I'm sure that many of us must have seen the different spectrum of behavior of simple bone cyst. Sometimes it's confusing what are the options available, because if we read the books, the treatment starts right from just active observation in a slab if there's a fracture, versus some injections, and even we have seen cases where people have to operate for it. So today I just compiled this talk with the evidence-based literature about what is the right protocol. So, if we look at the X-ray this is the classical characteristic X-ray. In fact, I think right from MBBS to orthopedic residency, we have seen this X-ray where they say that it's seen in a central lucent zone in metaphyseal region with a fallen fragment sign, which is the piece of the bone which falls in this cavity. These are benign lesions, and the MRI is helpful in characterizing the lesion, that these are purely cystic. Generally, there are no heterogeneous enhancements in these lesions. So this simple bone cyst is also known by many different terminology, namely like unicameral bone cyst or solitary bone cyst. Many a times it can be a radiological differential for other benign tumors like aneurysmal bone cyst, which is relatively, I would say, eccentric, expansile, shows multiple fluid levels to differentiate, and it is much more aggressive than the conventional simple bone cyst. The other differentials can be in a mature skeleton when it is epiphyseal, it can be giant cell tumor. Sometimes In a diaphyseal, it may be simple bones, your fibrous dysplasia, Langerhans. These are all radiological differentials. So if we talk about the pathology, so the first time when it was described was in 1891. So more than 100 years ago, the description was given for the simple bone cyst. And there were different theories which were proposed regarding the development of these bone cysts. Especially, it was said that due to venous blockage in intraosseous, it leads to erosion of the bone, expansion of the bone. Few theories postulated that it is also post-traumatic, and sometimes since it was seen mainly in the pubertal age when the child grows, a developmental anomaly was suspected. The recent studies have shown that there are few enzymes and chemicals like interleukin-6, some proteolytic enzymes and lysozymes, which are there in this lesion and which are responsible for the lysis of the bone. Overall, if we see, it has a broad spectrum of treatment. Traditionally, open surgery were done. Gradually, we moved to conservative and more conservative. And the recurrence rates vary between the type of treatment that we choose in the management of these lesions. So I will just take you through this case example. So this was a young boy and who presented with pain in the proximal arm. So once we see the lesion, what are the factors that comes to our mind to decide whether we need to treat it or just observe it or we need to do any intervention? So I would say 2 points we need to see. One, is it an active cyst or passive or latent cyst? How do we know that? So active cyst is the cyst which is less than a centimeter of the growth plate. And we also need to see whether there is any pathological fracture. The natural history of the cyst is in a way that usually it starts metadiaphyseal and then it gradually moves towards the diaphysis, and as the child grows, it gets absorbed. So if we look at the literature, the treatment of simple bone cyst, like I said, it has a wide spectrum, right from observation in a POP cast to decompression, steroid injection, bone marrow injection, to open surgeries like curettage, bone grafting, and in one of the rare aggressive scenarios, we may have to resect it also. So we will see what I follow, that I will share it with you. So my principle is, when I see a simple bone cyst, my principle is to do with a minimal intervention and to get the maximum benefit. That is my philosophy. Because we know the pathology, we know the physiology, that there are increased interleukins, prostaglandins, lysozymes. So I use a minimally invasive technique to attack multiple points of the cyst formation. So this is the routine. I prefer a percutaneous technique. Like the reason why even a simple fracture in a simple bone cyst, a fracture in a bone cyst allows its healing is because it decompresses the venous congestion that is there. It releases all the enzymes which are collected there and starts healing. So in these scenarios, what I prefer is to go minimally invasive with percutaneous needle. I scrape the walls as well. Plus, I inject methylprednisolone, the steroid, and I also clean the cavity by aspiration. So I'll share my video with you regarding the procedure, how I do it. I think there is some lag in the video. Let me just check it. I think I'll just play the video directly if it's not happening.
Yes, sir, that would be better, I guess.
So this is the percutaneous way by which first I insert a Jamshedi needle. I try to curate the walls of the cavity. In this way, I reach the different nooks and corners of the cavity.
Vivek, sir, we can't
I
see the
prefer
video.
to. Is it visible? My screen?
No, the screen is visible, the video is not.
So depending upon the length of the cyst in the cavity, I insert like one needle or even two needles. In this cavity, I use two needles, and through one, I inject normal saline,
Vivek,
and
sir,
through the other one,
I,
I aspirate, so that the cavity inside, whatever I have curated, it's also gets clean.
Vivek, sir, sorry for interrupting, but your video is not visible.
So the real advantage is that it is a minimally invasive percutaneous technique. Sometimes we need not even suture it. It can be just close like that.
Vivek,
So multiple
Vivek,
repeated aspirations are done
Vivek, can you hear us?
to clean the cavity.
Your video was not
And
playing.
then I inject steroid inside the cavity. So since there was two needles, we block one of them so that it doesn't get aspirated. And through the other one, we inject the steroid. So usually I use methylprednisolone, which is given in a dose of somewhere between 80 to 160 milligram. So once we have injected it completely, we again block it. It is natural that if we inject it inside the cavity, there will be some overflow, but it is not going to cause any damage.
Dr. Vivek, can you share the screen once again?
So I'll just go to the PPT now. So this is the response with a single injection.
Vivek, we cannot see.
Vivek, sir,
We cannot see your screen.
Now this is another scenario where there was another young boy and he sustained a pathological fracture. And once we evaluated, there was a pathological fracture. Initially, he was operated elsewhere. Yeah, Pradeep. Acha, let me see. My screen is not visible.
no, your video was also not visible.
We didn't see anything, Vivek. No video, no screen.
1 second.
So initial slides were there, but once you started sharing video, I think we lost you.
We
Yes.
can see your
Is
slide.
my screen visible now?
Yeah.
Yes. You'll have to just go back a bit. You can start after the video.
Pratik, can you see my screen?
Yes.
Right. So, right. So this is the, sorry, I think once I jumped from my video to my PPT, this was, I was out of this screen sharing, I think, automatically. So this is the response that we saw, that it lead to ossification of the cavity. Now I'm sharing the another scenario where a young boy who sustained a pathological fracture in the proximal humerus. He was initially evaluated elsewhere. And after this fracture, he was managed initially with external fixator and a tense nail. So this is also one way of correcting it. Later on, the external fixator was removed, then nail was kept in situ till you can see that the cyst started ossifying. And if you can make out initially the cyst, which was reaching up to the growth plate, gradually is shifting down the line. So for simple bone cyst, if we have to conclude, the spectrum varies. The spectrum ranges right from your observation in an incidentally detected or in a latent cyst where the patient is asymptomatic. We can splint in a slab or brace once there is a cortical breach or pathological fracture. That is also right. But many a times what we see there is that the parents are quite apprehensive with the fracture, and they need to be counseled very well that this fractures definitely heal over the time. And in some percentage of cases, we may have to splint them. If there is gross displacement, then probably doing a tense nail would also suffice. The percutaneous techniques like decompression and with needle aspiration, injection of the active cyst, injection of steroids and other like bone marrow injections have also shown healing. Surgery is reserved for, I think, refractory cases which are recurrent, non-responding, and probably where there is a lot of bone destruction which cannot be managed conservatively or with minimal interventions. And finally, I think the most important point is that we need to individualize the treatment. We have to look at the site. Usually in upper limb, we can do that, but in lower limb, we need to give some sort of splintage or internal fixation to give stability, the amount of bone destruction, and the presence of pathological fractures. We need to take into account all of these to finally identify and choose the best treatment plan for our patients. So thank you. We can discuss if there are any questions.
Sir, what is the role of biopsy in SBC, sir?
So see, if there is a characteristic presentation like the first X-ray I showed, in a premature skeleton, you have classical X-ray findings of central lucent zone, fallen fragment sign. So these are characteristic, and we need to confirm it also with MRI. So if it is there, probably we can label it as simple bone cyst and go ahead with the treatment planning. But in any atypical scenario, if suppose it's a mature skeleton and adult patients and there are some heterogeneous lesion, then we must go ahead and do the biopsy. We must not assume.
I think identifying a simple bone cyst and just on the basis of radiology and clinical presentation is really should be left to the experts. For anybody else, one should work up the patient well, at least for once with an MRI, and whenever you are planning some sort of intervention, you should take some tissue and send it to the pathologist for documentation. Because sometimes telangiectatic osteosarcoma or even ABC, can really in the very early stages present in a way which looks like simple bone cyst. Often the quality of X-ray is not so good that you can really see all the features very well. So in all these circumstances, we should be really careful. Simple bone cyst, although it sounds very simple, is not as simple as we make it out to be.
Yes, sir.
And if the patient has a long history, generally that is where I always draw the line. If the patient says, I had history of repeated fractures over the last few years, it has happened 3-4 times, every time it heals with conservative management, and then he again comes up with something like this. If such a patient comes to me, then I will be far more comfortable, calling that as definitely, a simple bone cyst. On the other hand, if he is presenting for the first time, I always feel thorough documentation of it at the first contact is a way of establishing it for good about what you are dealing with. And
Absolutely.
the other thing is about the location of the lesion. How would you treat it depending on whether it is involving the humerus or the femur? Will it be different? Pratik, would you like to take that? Or Vivek, you're back.
Sir, absolutely. Whatever points you raised are very valid. I think the most important point you said depends upon the expertise of the surgeon. So if somebody who is orthopedic oncologist and trained and has seen high volume, so it's just easy to identify. But always we should keep a high index of clinical suspicion whenever we should never assume this to be a simple bone cyst. And like our next question somebody has put up, do you do the MRI in simple bone cyst if seen on X-ray? So I think the answer is yes, because only a radiology with X-ray might mimic different lesions, like sir said, aneurysmal bone cyst, telangiectatic osteosarcoma. So X-ray, apart from X-ray, the MRI gives further characterization of the lesion. It can help you differentiate between simple bone cyst, aneurysmal bone cyst, any sarcoma. So MRI is must, and then only we must conclude that it is like simple bone cyst we are dealing with. Sir, your points?
I agree, because I can cite at least two situations where I was so confident that I was dealing with a simple bone cyst, but which eventually turned out to be aneurysmal bone cyst as they progressed in their, evolution of their lesions, where I conserved and then I realized it is just becoming worse by the day. So that's the reason why I, really strongly feel that, some way of documentation is the best thing for the patient. I mean, finally, we are doing it, to secure their health, and that is our responsibility. We can't just base it on guesswork or, a matter of chance.
So this is also very important point, sir, that orthopedic surgeons always ask. So what will happen if I just go in and fix in? So what is your point on that? Sir, I think you are muted.
So again, doing that is like taking a chance. And you are not taking a chance with your health, you are taking a chance with someone else's health. And it depends on what level of responsibility you are willing to take in case you are wrong. Is that fair? And would you be okay with, being treated like that? And especially when it comes to children, parents, and family are very sensitive to, the outcome of what you do. So it is up to us to convince them that this is in their best interest, and it is for that. Maybe they may be right 99% of the time, but that 1% of the time where they can be wrong can still be a problem for that one particular patient. So going about working up a tumor in a very methodical manner takes away that, even that small risk where you may be wrong. And I don't buy the excuse of, cost, that, the patient cannot afford an MRI, or, doesn't want a biopsy because it is going to cost. Not really. Because if you get it wrong, the price that they have to pay is much, much worse. And there is
Yes.
no way to, calculate that.
It's about both the limb as well as life.
Exactly.
So I think a very important message that we must always identify and diagnose and then only proceed with the treatment planning. So we also have more faculties with us, very experienced, Dr. Devesh Jalan, Dr. Jamin, Dr. Lokesh, and Dr.
Yes,
Deepak.
yes. It will be
Anybody?
great to have their input
Yes,
too.
please.
This is a common forum. I mean, even I am here to learn. So anybody's experience, is always valuable.
Dr. Jamin, you want to add something?
Many. I mean, there is nothing more to add. Whatever, sir, and it's absolutely on target. Means you cannot miss any one point when you are treating with tumors. You can just guess it. Okay, by it can be a simple bone cyst, and let me just fix it. So whatever sir said and whatever you have pointed out, it's absolutely fine. The bottom line is you cannot miss any step. That's what I can say at last.
Right. So our audience, if they have any questions, otherwise we'll move on to the next lecture by Dr. Jamin Shah. Dr. Jamin Shah is a senior orthopedic oncologist in Ahmedabad, and he was formerly in GCRI. And today he's going to talk about aneurysmal bone cyst. Over to you, Dr. Jamin.
Dr. Jamin starts. The participants can ask the question in the chat box. So we'll try to answer them during that. Yeah.
Is that fine? My screen is visible?
Yes, sir. Yes, sir.
Yes.
Go ahead.
Okay, fine. So, first of all, good evening, everybody. Thanks, Vivek. Thanks, Sarcoma Education Foundation for including me in this program. So, topic for my today's talk is aneurysmal bone cyst, and specifically it was evidence-based management. So, I will just run through some of the slides just for basic introduction of what is an aneurysmal bone cyst. And majority of my talk will be on what is the current and evidence-based management of aneurysmal bone cyst. So ABC, that's an aneurysmal bone cyst. So traditionally, it's classified as a benign bony lesion, and more specifically, it's not a pure benign contained lesion. It's a benign aggressive lesion. So as we heard in the first talk by Dr. Srimant and the discussion that what are the stages of a benign tumor. So latent, active, and aggressive. So ABC can be considered as an aggressive benign bony lesion. So what is a benign aggressive lesion? So there is a marked bone destruction. There might be some soft tissue extension, and it can also lead to a pathological fracture. So considering the etiology, so it results from a local circulatory abnormality. So the theory that is proposed is there is some increased venous pressure, which leads to some local hemorrhage, and that the products of that local hemorrhage, hemosiderin, everything causes local osteolysis, and again osteolysis causes more bleeding, and the whole circle gets continued by its own way, and the lesion keeps on increasing. The source of bleeding usually is the small capillaries which are present in the cyst membrane. They are not major arterial vessels, but there are some small capillaries which are present in the cyst membrane which gets ruptured and causes that aneurysmal bone cyst. And the hemorrhage progresses to the destructive lesion. Just a slide on demographics. It's more often seen in younger patients, preferably less than 20 years. Females are more commonly affected. And the location. So it is most often located in metaphysis or metadiaphysis of long bones, proximal humerus, distal femur, and proximal tibia. Occasionally, it can involve the pelvic bones or the lumbar vertebra. So going on to the diagnosis, X-rays are the again most important step in diagnosing an aneurysmal bone cyst. So as you can see, this is a case of an aneurysmal bone cyst of a distal tibia. So what are the characteristic findings? So it's an expansile lytic lesion which elevates the periosteum, but usually it is contained by a thin shell of cortical bone. It is a well-defined margins or a permeative appearance that mimics a malignancy in aggressive cases. And it grows eccentrically. So this is a differentiating point from a simple bone cyst, which is more centric, and aneurysmal bone cyst is much more eccentric. The classical picture or a classical diagnostic sign on when we tell that the patient has an aneurysmal bone cyst is such sort of finding when you get an MRI of that patient and you classically see these fluid levels, then you are pretty sure that it can be an aneurysmal bone cyst. So remember my words, it can be an aneurysmal bone cyst. So why such fluid levels are obtained in a patient with an ABC? Because the multiple cysts are there, and in that the blood starts settling down, and the hemosiderin which is present in that, this gives rise to multiple fluid levels, and this is one of the characteristic sign of an ABC. But mind well, this is a very much confusing sign with a very grave disease known as telangiectatic osteosarcoma, which definitely shows such sort of fluid levels. So it's your responsibility to not stamp ABC to each and every MRI which has a fluid level. It can be an aggressive telangiectatic osteosarcoma. So I just searched and tried to find how to differentiate between aneurysmal bone cyst and a telangiectatic osteosarcoma. And this is what I got to know, that in aneurysmal bone cysts lesion, the pattern of bone destruction which is there, they are completely filled with fluid levels on MRI. Means there is no solid area or some lytic area or a vacant area which is present in the whole cyst. So if the whole of the area is completely filled by that fluid level, you can be pretty much sure that you are dealing with an ABC and not with an telangiectatic osteosarcoma. But always a needle biopsy has to be done to confirm that what you are dealing with. So if you do a biopsy in aneurysmal bone cyst, what the pathologist will see is such sort of cystic spaces which are lined by a fibroblast, and osteoid is present, but that is a sort of a benign osteoid. Whereas in case of telangiectatic osteosarcoma, you will get same cystic lesions, but an aggressive or malignant osteoid will be present in those lesions. So this is how clinically, radiologically, and with pathologically you differentiate between an ABC and an telangiectatic osteosarcoma, because both of them, the path of treatment is exactly different. Again, I tried to search what is the recent management. So there is a role of USP6. So what is USP6? It's an gene which, if done, confirms the presence of ABC, but it's not 100% sure. So a USP6 rearrangement is present in approximately 60 to 70% of ABC cases. So there are centers which do these tests to confirm whether they are dealing with an ABC or some other scenarios, because ABC component can be present in other diseases such as GCT, chondroblastoma, and elsewhere. Again, moving on to differential diagnosis, there are whole lot of benign bone disease which can exactly mimic an aneurysmal bone cyst. So these are whole set of disease which can mimic aneurysmal bone cyst. But management wise, I think you need to differentiate an ABC with a telangiectatic osteosarcoma. That is most important. And the previous slide which I showed, it was the sole criteria of showing that was you need to differentiate between those two and how you can differentiate it. So coming back to the main part, that is management and evidence based. So I will just try to share some of the latest or the path breaking papers which are there in aneurysmal bone cyst. So when I search the net for management of aneurysmal bone cyst, what I got is there were 1,333 publications. So out of those, approximately 800 were of simple bone cyst, and approximately more than 800 were of aneurysmal bone cyst. So there is a very heterogeneous pathway for management of aneurysmal bone cyst, practiced differently at different centers. But I will try to formalize a simple pathway. Basically, the treatment of an aneurysmal bone cyst is between these two things: either to do an open surgery, or recently the development is whether you can treat it in a minimally invasive method. So let's see what you can see. So this was the traditional method of doing an or treating an aneurysmal bone cyst, in which you made a big cavity just like a GCT, use burrs and whole sort of thing, and then pack the cavity with bone graft to treat an aneurysmal bone cyst. But as you can see here, there were lot of tissue damage, lot of trauma, lot of loss of original bone stock in treating such benign aneurysmal bone cysts. So there were a lot of research going on whether we can treat it in another way. And this is the landmark paper which drastically changed the treatment of aneurysmal bone cyst. And this was a landmark paper from AIIMS Delhi, in which they treated aneurysmal bone cyst with the help of an sclerotherapy. So what is sclerotherapy? I will just share in my later slides. Basically, what they did was approximately 1 ml of 3% polydecanol. So polydecanol is a sort of an sclerosing agent which the general surgeons usually do it in sclerosing the varicose veins. So these people use that polydecanol and injected 1 ml per 1 centimeter cube of lesion or volume of the lesion into the cavity, and then they just waited for the lesion to heal. Took check x-rays after every 6 weeks, and then just waited for the lesion to heal. And with this treatment, these are the results that they got. These are the images that I have taken from that original paper. And depending upon, and they got about 85 to 90% of cure rate for aneurysmal bone cyst with this just simple technique of just injecting these polydecanol into that cyst. So depending, so from this paper, there was paradigm shift in management of ABC, and people started using these minimal invasive techniques and started refraining from doing an open surgeries in aneurysmal bone cyst. So this was again what I say, backed up by European centers also. As you can see, this is a paper from UK, where they just went ahead and give one more term, which is known as a curopsy. So what was curopsy was, curopsy is a percutaneous limited curettage. So at the time of biopsy, they just obtain the lining membrane from various quadrants of cyst, and by doing so, they also noted that lead to consolidation. So these are the very minimally invasive techniques that developed in last few years, which help in treatment of aneurysmal bone cysts. Again, this is a paper from Germany also. And again, this is what they found out, that the study confirms that the efficacy of polygonal installations for primary ABCs justifies it as a standard treatment option. And again, this is way back paper from TMH, recent paper, which also backed up that percutaneous sclerosis therapy with polydiaconal is effective in treating primary aneurysmal bone cyst. And you can see the results that they got is overall 84% of lesion healed after one or more injections of polydiaconal. And again, the conclusion was same, that percutaneous sclerotherapy using polydiaconal is a safe, effective, minimally invasive, and inexpensive method of treating a primary ABC of limb or in pelvis. Again, the crux is percutaneous treatment modality gives good results in ABC. So if I tell you what we do is, we just insert our Jamshedi needle into the lesion under IATV guidance, aspirate the whole of the blood-filled cavity, whatever you can, and then we also try to just remove all the lining of that cavity by moving the needle in all directions or breaking all the septas and getting out that membrane from the lesion. And then we inject this polydiaconal injection. The volume of polydiaconal what we inject is, as I said, is approximately 1 ml per 1 centimeter, 1 millimeter cube of the lesion. But usually we don't inject more than, personally I don't inject more than 4 cc of polydiaconal into a cavity. So this is one of the case. As you can see, this was a lytic lesion confirmed on MRI and biopsy that it was an aneurysmal bone cyst. So think that if there were no polydiaconal during this time and you got to treat these lesions with that open curettage and grafting, I mean, these are very difficult place to treat with an open surgery. But thanks to this minimal invasive technique that we injected a polydiaconal, and this is an excellent response that we got in follow-up X-rays, and absolutely patient was absolutely fine in routine follow-ups. Again, these are another case of a young chap. As you can see, multiple fluid levels, diagnosed aneurysmal bone cyst. This was a pre-installation X-ray, and this was a post-installation follow-up X-ray. And as you can see, it was completely ossified, and the kid had a good range of movement. So there are also other modalities, if I can touch upon, in treating an aneurysmal bone cyst, and these are some of them. First is selective arterial embolization. So if you have an aneurysmal bone cyst, very giant ABC of a pelvis or a spine, where it is very difficult to instill sclerosion, then you can use, or you can use in combination with it, embolization. So selective arterial embolization stops the bleeding, feeding vessels, and we can get a good healing rates with this technique. People have tried multiple other percutaneous agents, which are known as sclerosing agents, such as DBM, doxycycline, alcohol. But personally speaking, I do not have any experience in using such agents. But there are reports and papers who have used these agents and have got good results. Use of denosumab, I don't know. Again, there are again some case reports or very small case series reports where denosumab is used in ABCs, and they also have got good results in terms of getting good treatment in ABCs. Use of bisphosphonates, again, I don't know. I also have never used bisphosphonates, but as I said, where the lesion is very large, spine, pelvis, or some other areas where only one modality you think will not suffice, then you can use these sandwich of things, such as do embolization, do sclerotherapy, use denosumab, or use bisphosphonate. This is just to avoid a major surgery, and we can get good results. So again, I think this is my last slide. So again, what's new in muscular tumor surgery? This was an article in 2020, and for that, in ABC, primary ABC is treated with percutaneous sclerotherapy. 84% of primary ABCs were successfully treated with percutaneous sclerotherapy. And I said, favorable results and no meaningful complications were seen in this large series of sclerotherapy treatment. So to wrap up my talk, if I say that what is the current evidence of treatment of ABCs, then I can stamp it on my side that percutaneous therapies are giving excellent results in treatment of ABCs. I think that's the last time. Thank you.
Thank you, Dr. Jamin. And I think you comprehensively covered this topic very well. So if we have to see, is there any question related to that? So fine. So how do you plan your curopsy? In all cases of suspected ABC, how do you decide that?
So basically, I don't do a curopsy on the prima facie thing. So usually I always biopsy first, whether I am dealing with an ABC or an telangiectatic osteosarcoma. So biopsy principles remains the same, but because in such cystic cases it's very difficult to get tissue, I just try to remove the membrane of that from cavity from 1 or 2 species, try to get good material, have a proper diagnosis that it's an ABC, and then again go in for the second time. So on the second time, I again go in the same way, localize the lesion in IITV, and I always do this procedure in general anesthesia because these procedures are extremely painful. Because as soon as you enter the needle and aspirate, all the negative pressure causes extreme pain and patient will not able to be tolerate. So always do it in general anesthesia, confirm your position of your needle under IITV, and as I showed you, scrap all the walls, whatever you can, just to break all the septas and just separate the membrane from the lining. And then again aspirate it, aspirate whatever amount you can, maybe once, twice or thrice. Once you are happy that you have aspirated quite enough blood, then instill polydecanol according to the doses. Inject the polydecanol, wait for 2 to 3 minutes because these are very pulsatile. I could not share a video. I had a video of a needle. As soon as we place the needle into the lesion, you can see the pulsation of the blood coming out of the needle because it's an pulsatile cavity. So wait, after instillation of polydecanol, wait for 2-3 minutes and then again use a normal saline just to again push that sclerosant again back into the cavity. Again,
So,
wait for 2-3 minutes.
Yeah, let me ask one question from all the panelists here. Is there any limitation on the dose of polydocanol? How you decide? Dr. Jamin first, then Chetan sir.
So classically, as I told you, 1 ml per 1 centimeter cube of volume, that is what is recommended, and no more than, on the original paper they had told you not more than 10 ml. So but usually such sort of large ABCs, it's very rare to only treat by only sclerotherapy. You need then 2 or 3 more things. But as I said, personally, I have injected maximum 6 cc, but then you can repeat the doses. So that is another way of treating such large cases.
Chetan sir, your opinion?
Yeah, I mean, the recommendation is 1 ml per cubic centimeter volume, no? That is what they say.
But sometimes we see very large, especially.
But not sometimes. In fact, majority of them are probably 100 ml or more.
Yeah, we don't
I
see
mean, I honestly never got that. How can you say 1 ml per cubic centimeter of volume? Because I have never seen a 5 ml ABC in my life. It is at least 30, 40 or more, never less than that.
Yes.
And if it was really that small, I would probably prefer to curate and graft it rather than, go with the uncertainties of a, sclerosant injection.
And especially if it is in the lower limb, where the chances of pathological.
Yes, there is a risk of fracture. I want it to be resolved quick. In fact, curopsy and all, I would reserve for the much larger cyst where after curettage also, I really don't know what to, stabilize or fix it with, especially if it is in the pelvis or, in difficult locations. So
yes, sir. Please complete.
I would use 5 or 6 ml. I wouldn't dare to use more. The other thing that I do is I basically increase the volume by creating a foam out of it. Basically, you use 2 syringes and a two-way thing and mix air with this because it is basically soap. It's a soapy solution and it forms a foam and that will give you a larger volume. But as Jamin rightly said, you should not just inject sclerosant, you should also do a percutaneous scraping of the cyst wall, the so-called curopsy kind of procedure, and then inject, this sclerosant, so that you use multimodality, management to sort of deal with this particular cyst. I had mixed experience with sclerosant, and I have had cases where sclerosant failed and I had to operate, and I had cases where surgery has failed but sclerosant has worked. So
Yes.
we have to keep our minds open, and as Jaimin has rightly said, you will have to keep repeating this procedure. Even in that paper from AIMS, which came in the JBJS, they said that 3 to 5 procedures
Yes.
is needed per patient. It's very rare that you will get a good result with a single, injection.
Yes.
Yeah. So before I proceed to the next question, just let me make an announcement that at the end of this our discussion, there is a quiz for all the participants, and there is gift item also. So request everyone to download Kahoot. Probably Pratik, you can quickly say that people who have not yet downloaded it can, or everybody has downloaded it. So that we are ready at the end of this.
Yes. Thank you, sir. Thank you for that reminder. So it's a simple app, Kahoot app, Kahoot. It's available on Play Store, and which you can download on your phone. And then we can be able to play the quiz. So in the meanwhile, I think we can start with the panel discussion.
Yes. So let me introduce my panelists today. I know it's a short time, and since I'll keep last 15 minutes or 20 minutes for the quiz, let me introduce my panelists first. Our speaker, Dr. Jamin, he is a senior orthopedic oncologist in Ahmedabad. So he is one of our esteemed panelists. Then we have Dr. Devesh Jalan. Dr. Devesh is associate professor in Safdarjung Hospital, Delhi, and he's there. He's presenting the first case. Dr. Deepak Garg, orthopedic oncologist from Delhi, and Dr. Lokesh Garg, who is a consultant in Narayana Healthcare, Delhi, and Gurgaon, is our another panelist, along with me, and Chetan sir is always there to pitch in. So before I move into the next session with Devesh Jalan, 2 quick points I want to say about ABC. In fact, let's start the discussion here only. So how do we do the biopsy in aneurysmal bone cyst? Because, this is the common question asked by orthopedic surgeons. It's the only blood cavity. If we go inside, there is frank blood. We never get anything on the histopathology. Dr. Devesh, you want to add anything to this? Then we move to Dr. Jamin.
Yeah, basically, for a biopsy in an aneurysmal bone cyst, because most of the times there is no soft tissue there. So you just have a cystic cavity, and when we go for a biopsy, we just obtain blood. So what we used to do is that we obtain, if we are able to get some septa, or if we are not able to get the septations, then we try to curate the walls.
Yeah,
so
that is
normally
important.
when we curate the walls, we usually get some kind of a cyst wall lining, and then we send these cyst wall lining, because the first evidence which we get when we aspirate, and if we get blood, then more or less we differentiate that it is not a simple bone cyst. Because if we are considering a simple bone cyst as a differential in some cases, then this is one indicator which tells us that it is not a simple bone cyst. And then if we are not able to get anything inside the cavity, if it is an empty cavity, then we try to curate the walls, and whatever tissue we get it, we send it for sample. So that is
for practical purpose, I would say that if this is your Jamshedi needle and this is your cavity, once you go pierce the wall, you go to the opposite wall, you keep curating and keep a negative suction so that the curate from the walls are sucked up in your needle.
Yeah.
Great. Now, second point about the sclerotherapy in ABC. So once we started, we have seen that sometimes even if you don't use sclerotherapy, sometimes even with the biopsy, the lesion starts healing. So curettage of the wall, which destroys the lining layer of the cavity of the ABC, is also very, very important step. So whenever we are planning, if we are almost sure based on the radiology, based on the MRI, and with our experience that it's ABC, we can do the curettage percutaneously, not the open curettage, while doing a biopsy. That also leads to healing of the lesion. So right, over to you, Dr. Devesh. Please start with your case. And I think we'll go quickly. You can keep asking the question so that we have time for the quiz. That is going to be interesting.
Is my screen visible?
Not yet. I can see just your name.
Just a minute.
I think Jamin, you have to stop sharing your screen probably then.
I think I already stopped sharing.
Okay.
Just a minute. Is it visible now?
No, not yet.
I've started the share screen just a minute.
Okay. Yeah,
Is it
it is
visible?
visible.
Yeah. Okay. Yeah, so I'll be starting with the first case for the panel discussion. A 20-year-old female, she presented to me in May 2016, and the chief complaints were pain in the right hip and thigh for last 2 years, but it was progressively increasing for last 3 months. And she also had swelling in the right thigh, which was again for 2 years, but it was more or less static and was not increasing in size. She also had difficulty in walking, squatting and sitting cross-legged, and she has some history of surgery which was done for the right femur lesion outside in August 2014, following which she was asymptomatic for a year, and then again she had these problems afterwards. The nature of the lesion was not determined at the time of primary surgery. She had no documents of any biopsy at that time. There was no history of any trauma, fever, or any other constitutional symptoms. And there was no history of any other similar complaints in other parts of the body. On examination, there was multiple healed longitudinal scar over right thigh. There was a bony hard swelling, as we can see in the proximal femur. There was some tenderness, particularly on the lateral aspect of the femur in the proximal region. Shortening was around 1 centimeter. Range of motion of the hip was limited. Flexion was around 80 degrees. Extension was 10 degrees. Abduction 20, adduction 20, and rotation was painfully restricted. There was no distal neurovascular deficit. So these were the initial X-rays which were available with the patient, and I can have some opinion from the panelists. What do they think, and what is their probable diagnosis, and if they have any comment to make on these initial X-rays.
So if I look at the X-ray of October 2014, I see that there is an expansile lesion with ground glass opacity in the metatarsal lesion of femur with the nail in situ. The hip is in coxa vera. There is joint collapse. And if I see in October 2015, yeah, so 1 year later, the collapse, probably the head is like what we call Shepherd's crook deformity, that is progressing, and probably there is some sort of pathological fracture there.
Yeah,
the implant has broken. Yeah, the implant has broken.
Yes, so there is the implant, obviously the marker which I have put of the yellow arrow. So the implant obviously has broken, and we can see also on the lateral aspect that there is a pathological fracture as well. So there is some break in the cortex on the lateral cortex.
Yes.
If we can see closely on the X-ray. So that's when, that is, she was asymptomatic for a year, and it is after a year, because of these collapse and the implant has failed because of the continuous stress rises, she has started to develop pain and some amount of swelling.
So let me ask, okay, so let us ask our other panelists as well. So if this was the situation with in October 2014 patients with this condition, what else you would have thought of? Dr. Deepak, Dr. Lokesh?
Hello. Yeah, good evening, sir.
Good evening, Lokesh. So any pharmacological measures or anything else, any other surgery, or are you okay with surgery?
I would have started bisphosphonate also with October 2014 after putting a nail in this case.
Right. And do you think just putting a nail was sufficient, or probably you would have to do something more?
Sir, actually the bone graft most of the time get dissolved in the fibrous dysplasia.
True.
Or we can put a cement also in this case, but I think giving a bisphosphonate would heal the lesion, and I think the nail nail will suffice the stress over this lesion, that can prevent the pathological fracture in the initial stages, and then the bisphosphonate will heal the lesion.
Okay.
And
So Deepak, yeah, Dr. Deepak, you want to add something?
So, so I agree with Lokesh, sir. Uh,
So bisphosphonate is something which we should have started.
after starting the bisphosphonate, we should have we follow the patient, sir, whether there is an improvement in the lesion, sir.
Right. So looking at the radiology, we are okay with this, that it is a fibrous dysplasia. It fits well, multiple lesions as told, and ground glass opacity, and with yeah, Shepherd's Crook deformity, right? What is the indication of surgery in fibrous dysplasia?
sir, when a pathological fracture about to happen in a lower limb, it is then the prophylactic fixation should be done in fibrous dysplasia.
Yes. So I think impending pathological fracture, deformity, like in this case, it was Shepherd's Crook deformity, progressive coxa vara, it was moving on. And once the patient sustains a pathological fracture.
Yes.
So these are indications for surgery. In my opinion, what I feel that probably a corrective osteotomy would have been also done rather than just doing a nail and prophylactic fixation, because we need to correct the neck shaft angle deformity. Otherwise, it would be progressively going into varus and finally ends up with the fracture and implant failure. Okay.
Totally agree. So moving on with the case. So this was when she presented to us in May 2016. So after 2 years of surgery, basically the lesion, the fractures, as we can see that there are multiple septations in the lesion, which probably suggests that there are multiple microfractures which has healed over a period of time. And we can still see that the implant has failed. At this point, when the patient presented to us, she has significant pain and some amount of swelling in the proximal femur, and she has difficulty in her doing any daily activities of living. So now at this stage, we have certain questions like, do we need any other investigations in this patient? Or we are clear with this X-ray and this presentation that this is fibrous dysplasia and we don't need any other investigation. So we can, Dr. Jamin can answer. Anybody from the panelist wants to take it?
Yes, obviously it needs some sort of management. So any other investigations? Maybe a CT scan and biopsy. Obviously, if I am doing any sort of surgery, whatever surety is it, I will definitely do a biopsy to confirm what I am dealing with. Treatment considered, I will definitely do some sort of surgery to overcome this deformity. And what sort of surgeries? I think we need to remove the implant, and as Vivek told, we need to do a subtrochanteric or a valgus osteotomy. And then type of fixation, I would always prefer a nail, because almost all of the femur is completely involved. So we need to protect that whole femur with a nail. And I think we can get away with a regular nail with a screws inside the head, and then put the patient on post-operative zoledronate. Regarding curettage, I'm not sure. I will go in and do some more curative curettage and put a strut grafts or that.
Yes, I agree with you on many fronts. I think we need to understand one more point whenever we deal with fibrous dysplasia, that there are two aspects. One is the pathology per se in the bone, that as the word suggests, that fibrous dysplasia, the normal bone cortex is getting replaced by the fibrous tissue because of genetic mutation. So we need to address that as well. That's very important. And second is the point about surgical intervention that varies from the surgeon's choice. He wants nailing or plating. That's all I wanted to add.
Okay, so basically, like in any other investigations, we basically have to differentiate whether it is a single lesion or a multiple lesions. So basically, once the patient presented to us, she has been just evaluated with this. So probably in a fibrous dysplasia patient, we may need to go for some kind of a skeletal survey or some kind of a bone scan just to find out whether we are dealing with a single lesion, even though patient is not symptomatic for other lesions. Or biopsy, basically, obviously the presentation and the X-rays were more or less, the biopsy is clear, and we all agree that probably it looks in favor of fibrous dysplasia because the lesion is progressing very slowly, and because the deformity has not been corrected. That is the main reason for patients' continuous symptoms and failure of the implant. And we all agree that obviously we need to go some kind of surgical intervention in this patient. As far as fixation is concerned,
Dr. Dev, just I'll hold on. I want to ask Dr. Pratik, do we have some more time after 7 o'clock, or we will have to finish that?
Sir, it's up to us, sir. We can continue the discussion if you want till 7, and then maybe
Okay,
later
so
on have the.
if I have to make
right.
it fast, then I can do it fast as well.
No, fine. It's fine. We will discuss till 7 the cases, and then we will move on to the question answer session. Lokesh, want to say anything?
Yes, sir. Actually, I want to ask Dr. Devesh, sir, what type of surgery you are planning in this case, actually?
Yeah, I'll move on with this case. Because this was a panel discussion. That is why I have kept what challenges I have felt.
It's a reverse bowling. It's back on the way.
Yeah. So I'll tell you what I have done in this case. So basically, the idea is that we need to go for some kind of surgical intervention. And fixation, obviously, there was some problems in choosing the fixation I had in this case, particularly because I was thinking of doing some kind of an osteotomy to correct the deformity. And after correction of deformity, what type of nail, if we are thinking of a nail, because there is a significant deformity, what type of nail we can use it? Or if we have a plate, then whether a normal plate or we need to make something like a custom made. So basically, I started with the
Actually, one thing I want to make a point. Actually, whenever we are planning for an osteotomy, the lesion should have healed completely. After then, we should go for a complete corrective osteotomy.
But then how do you ensure in a fibrous dysplasia patient that the lesion will heal? Because fibrous dysplasia is very resistant to healing. Yes. And till the time we correct the deformity in this patient, but my idea at that point of time was that till the time we correct the deformity, because the lesion is in the proximal femur and there is a continuous stress riser in the lateral aspect. So this will continue to have, even if you put anything, this stress riser will continue to be there and it will continue to give patient pain, even if we do give anything. So my idea was, what?
In this case, I think the pathological fracture is more problematic than the stress riser due to the
pathological fracture has healed. So by the time the patient presented to us, although there is thinning of the cortex, but the fracture has healed. So let's continue with the case, otherwise we'll get stuck on that point. So basically, I started with the medical management. I gave some kind of a bisphosphonate, alendronate, 70 mg weekly with some physiotherapy, because I was not very sure at that point that what exactly I'm going to do for this case, and some calcium and vitamin D supplementation.
One quick discussion here regarding the bisphosphonate therapy. Anybody using apart from alendronate? My personal, I use
favorite is zoledronic.
I use zoledronic injection.
Yeah. So basically, zoledronic acid obviously is a better choice, and even because the injectables have been found to be a good role rather than an oral therapy, but because of my patient's personal choice, I have started with this. So I continued at 3 months. When I reviewed this patient, pain has decreased. Although on the X-ray, I could not find any significant change. So I thought that probably maybe I can continue with this same management for some period of time. If this helps, then I don't need to do anything else. So, but at 6 months, when the patient presented, the pain has increased again, and there was significant difficulty in walking. So this was the X-ray at 6 months, and still I could not find anything significant, any major increase in consolidation or any change from the last X-ray which I have seen. So 6 months of a bisphosphonate therapy, patients initially improved and then again started to have significant amount of pain. So at this point of time, I thought that now I cannot continue more with the conservative management. So I planned for surgery. And my idea was still, because as a traditional teaching method, I thought that, okay, this is a fibrous dysplasia, but still I'll first do a biopsy, prove it, and then I'll plan for a definitive surgery, because that definitive surgery will not be a simple surgery. So I did a biopsy which confirmed it to be a fibrous dysplasia. And then I did a scanogram, try to find out the angle. planned for a corrective osteotomy because I thought that 30 degrees of corrective osteotomy would be okay. And then some amount, obviously we need to remove the implant. And there is, because of the distorted anatomy, I thought, because I was not very sure that whether I'll be able to put the nail again, because when I intraoperatively, when I removed the nail was protruding out from the lateral cortex. So so I thought that probably I will not be able, after the osteotomy, I will not be able to put the nail. So I made a custom made proximal femoral locking plate for this patient. And then obviously, because the normal autografts, cancellous autografts are not very good for fibrous dysplasia. So I also thought that I'll take the fibular cortical autograft and some amount of freeze-dried fossilized femoral head allograft. So this was my.
I will just emphasize that one point that in fibrous dysplasia, if we put the cancellous grafts, these also gets converted into fibrous tissue. So if you are planning to put any grafting, use stud grafts like fibula, which is more beneficial, or cementing, right?
Yeah. So this was my operative procedure: the implant removal, a corrective subtrochanteric valgus osteotomy, a 13-hole custom-made proximal femur locking plate, which was augmented with an intramedullary fibular autograft and an autogenous and allograft cancellous bone graft. Right. So this was an intraoperative picture, and proximal, we can see that there was a osteotomy. Although proximally I could not put more of fixation, but I have basically made a custom-made implant with some curve, because probably I cannot curate out the entire fibrous tissue. So probably whatever curating I was able to do, I have done that. So this was an immediate post-operative X-ray where I have done a valgus osteotomy. We can see the osteotomy site and the intramedullary fibular graft with the custom-made implant. So post-operatively, I managed the patient with some amount of toe touch and non-weight bearing for up to 2 weeks. And then I started with some gradual weight bearing. I continued with weekly bisphosphonates and calcium and vitamin D3 supplementation. This is at 6 weeks. And I thought that everything is going good. This is at 3 months. This is at 6 months, where the osteotomy site has more or less healed. There is a gradually increasing consolidation. Patient at this point has no pain, and patient is able to walk full weight bearing without any walking aid. These are the further post-ops, first after 1 year and 3 years. And this is the latest follow-up of December 2021. December 2021, where I think still the patient is asymptomatic. And I think the fibula has probably some consolidation is there. And latest follow-up, the scar is healthy. The patient has a painless gait. Shortening is around 1.5 centimeters. The range of motion has improved. The flexion, which was initially 80 degrees, now 120 degree. Patient is able to squat. Although rotations are still restricted and raise, obviously knee is okay, patient is able to squat. So this is the final follow-up of the patient. And patient is able to walk without any assistance. There is no pain.
Interesting case, definitely.
So, functional status, no pain, able to walk full weight bearing without any aid, able to squat, resumed her studies, and able to do all household activities. So this is what I have done, and I am willing for any critical comments or anything we can do else, anything else for this patient, probably. Yeah.
Thank you, Dr. Devesh. It was a good case, and I think the message was also conveyed that the treatment requires medical management, like bisphosphonates, as well as we need to plan our surgery very well, the corrective osteotomy, and it was challenging. So I think we are short of time. We can, if there is any question that can be put up in the chat box, we'll take to that. And
there is one question there on the chat box about the investigation of choice to rule out polyostotic fibrous dysplasia.
So I do bone scan, which can identify the lesions in a polyostotic fibrous dysplasia. So there are different types of polyostotic FD, like you have monomelic, hemimelic, where in the same one side of the body, multiple bones may be affected. Any other comments?
Yeah, I think probably I also go for a bone scan to find out whether it is monostotic or polyostotic. In case if I am not able to do it, then I probably will get some kind of a skeletal survey and to find out that thing. So these are the two investigations.
Comments from other panelists or Chetan sir?
I agree with you, Vivek. Some sort of full body skeletal survey, either with bone scan, which is the best investigation, I would say. Or nowadays, bone scan is difficult to get. In fact, PET is much easier. That's what I realized. So if bone scan is not available, a PET can also, do the same thing.
Right.
And it really doesn't matter much, to know whether it is polyostotic or not, unless it is, symptomatic. So I wouldn't really bother too much about it. I would just focus on the symptomatic part of the skeletal system, which is primarily the proximal femur and the pelvis.
Right, sir. So I think we can move on to the next cases. So this is a young man anesthetist, and he had pain in the middle phalanx. My screen is visible?
Yes, sir.
Okay. So Dr. Devesh, he had pain in middle phalanx. So what is your opinion on this?
Yeah, so I can see that there is an expansile lesion in the metacarpal and in the third metacarpal, and there is a pathological fracture along with that. It has a narrow zone of transition, and the margins are well defined. I can see some matrix, and probably my first differential in this case will be a enchondroma.
Right. What would be your next investigation? Would you like to fix directly or plan any investigation?
I'll go for an MRI, contrast enhanced MRI.
Okay. So this patient, wherever he was managed with finger splint, but pain persisted. When he presented to me, I did an MRI, which showed a chondroid lesion and along with a pathological fracture there. So coming to other panelists, Dr. Jamin, what is your choice now? So enchondroma with pathological fracture.
So almost 90% of with pathological fractures.
Okay, leave pathological fracture just with enchondroma.
So without, yes. So if I get an enchondroma without a pathological fracture, so almost 90% of cases I would conserve it, and almost 90% of my patients have came back to me and said, "Nahi, Doctor Saab, acha hai, everything is fine." So until and unless they are happy, I am happy. So I usually, it's a history of just trivial trauma with which they come back to me, and that pain usually subsides after some sort of analgesic, maybe not splinting also always, it's not necessary, and the pain subsides. So I usually keep them under strong follow-up, close observation, and if they feel that no, the pain is increasing, in rare cases where the size is increasing, displaced fracture is there, then I go in and operate them.
Right. So any other comments from Deepak or Lokesh for this enchondroma management?
Sir, in my opinion, I will go for a biopsy and then go for the second stage in this case. Actually, 40.
Okay.
Pathological fracture is there. Yeah, MRI shows the enchondroma, and mostly cases chondroid lesion in the hand or feet is usually the enchondroma, but age is 40, so I will go for the biopsy first and then operate curettage and grafting in the second stage.
So yes, the biopsy showed enchondroma only. What is the, now let us see what are the treatment of enchondroma. So this is just a summary of what Dr. Jamin said. Like we can do observation, especially in incidentally detected and asymptomatic lesions. For symptomatic lesions, we may plan our treatment. We can wait and watch, but especially if there is impending pathological fracture, depending upon the occupation of that patient, we may have to offer something definitive. So in this case, I planned for curettage, and we used artificial bone graft substitutes, and the patient is back to the routine activities. Any comments we can take on? I think this is the second case, which is similar to my presentation. So I'll just skip this. Let me come to the third case directly because we are short of time. These are.
Can we ask Chetan sir what he usually does with enchondroma?
Yes, Chetan sir, please.
Hi.
Yes, sir. Sir, what you usually
yes,
do?
I mean, I completely agree with what you said. I would conserve most of the enchondromas because, especially in the hand, because it's not a load-bearing bone, and this enchondroma has not popped up now. It must have been there for all these years, and sometimes with some, trauma, you may, develop a fracture. But more or less, most of them settle with conservative management, and there is no urgency or emergency with its treatment. So I would give the option to the patient of continuing to observe, and secondarily taking it up for any sort of treatment if at all there is a need for it, or the patient is extremely worried, or is continues to be painful or develops another fracture.
Yes, sir.
Yes, sir. Thanks, sir.
Particularly in this case, even I follow the same principle. But this patient of mine was an anesthetist, and every time when he had to intubate, there was a lot of stress.
So
And
you had
yes.
a very good reason to operate on him.
Yes.
Otherwise, this particular case, I would have preferred to
Yeah.
conserve. But then, that is affecting his
activities,
Daily
yes.
activities. Yes.
So this is also very important that as a surgeon, we understand the requirement of the patient and then plan our treatment. So coming to the third case, there is a young man who complained of pain in the leg for last 1 year. And Dr. Jamin, can you see anything abnormality?
Yeah, there is obviously a subtle, I think, periosteal reaction which is present on lateral aspect of, yes, that upper part of tibia. I think there is a soft tissue mass, or I'm just overseeing that X-ray shadow.
So I did MRI, and there was a cortical based lesion. He had a classical history of night pain and complained of pain at rest at night, and it was related with NSAIDs. So any other opinion from Dr. Deepak or Dr. Lokesh?
Sir, this is a most probably osteoblastoma, sir. We could go for CT scan to find a nidus, sir. And if after looking at the nidus, then we can go for RFA, sir.
Okay, so you have come to direct conclusion. Right. So I think it is important message when we go for MRI and when we go for CT scan. That is also a very typical question, because many orthopedic forums, when we discuss about cases of giant cell tumors, the first choice of investigation, or many patients who come to us with first investigation choice after X-ray CT scan. But we must understand certain investigations and their role. The MRI is very good for marrow-based lesions. It shows you characterize the lesion, shows the edema well. And then what is the role of CT scan? CT scan is very good for cortical-based lesion. But whenever it is marrow-based, like any sarcoma, soft tissue sarcoma, to look out for neurovascular bundle involvement, the MRI is the gold standard. Right. So as you said, I got the CT scan done. So the CT scan showed that there is a nidus there. So what is Lokesh? So what is your choice of treatment in?
Yes, sir. Nidus is very small, and I will go for a RFA.
Right. Okay. So suppose if RFA is not available, the patient is in some remote periphery.
Yes, sir. Then could drilling the nidus with a drill hole. And
okay. Very good. Right. So, Dr. Jamin, anything else you want to add up?
Yes, obviously, RFA is the best choice. But anybody going for for example, just I am asking, if that lesion was on superficial part and no RFA and no drilling, CT availability is not there. So then what will you do? Will go and excise that part?
No, sir.
Just a question.
So I think one of the biggest challenge in osteoblastoma is to identify the nidus and treat it, because that is the source of pain. And nowadays, all of us sitting in big cities where this is available. But I remember still my post-graduation days when excision of the entire bone was done to take out the tumor, and then it was a big surgery, required admission for a day or 2 days with bone grafting. But nowadays we have different options. Radiofrequency ablation is something which is minimally invasive and preferred. That is what we did in this case. So we had to go from the anteromedial aspect, reach the nidus, and thermal coagulation of the nidus was done. But just coming to the discussion part, I'm going fast because we're short of time. This was also a young boy, 8-year-old, with osteoblastoma in the posterior cortex, and he was from a remote place, non-affording for RFA. So in this situation, there are two options. Like I said, the ultimate aim is to destroy that nidus in whatever way you do. You can drill it, you can bury it, or you can excise that part of the bone and fill in with the graft. The challenge is always to locate the nidus and approach it correctly. So we did open, and here you can see this was reflected the gastrosoleus, and behind that we reached to the nidus part and buried it completely. So I think we have completed, and we are a little bit ahead of our slotted time.
Sir,
So,
I have one question, please.
Yes.
Yes, sir. How to locate a nidus in a open surgery without CT? It could be very difficult, I think.
So it goes with the planning. If you have a CT scan done before, you need to identify the landmarks, measure the distance. That is one way of doing it. Second way is always get an X-ray done before, because if you can see the nidus on X-ray, it will also be visible on your fluoroscopy. Second, you need to make the coordinates. I use K wires. And finally, once I expose that area, usually if you see that the practical experience, because many of the patients who cannot afford RFA, we do open. I prefer to do open burring with the high-speed burr. So there is a sclerosis formation. There is a thick periosteal reaction, and somewhere in the central part or in the either proximal or distal, based on your CT scan findings, you locate that. And if you have still doubt, then you can excise that part of the bone, whichever is showing thickening and periosteal reaction, so that the nidus is out. But a preoperative planning is must.
Yes, sir. Thank you, sir.
Right. So, sir, comments from Chetan, sir. We have come to an end of this session today, and now we will be moving on to quiz competition.
Very well covered. I think I thank all the faculty and Vivek for a very interesting session on non-GCT benign bone tumors. I think whoever has attended will be enriched by today's informative discussion on all these various pathologies that we face. I congratulate all of you on a very nice program.
Thanks. Thank you, sir.
So, Dr. Pratik, I think we can go through the quiz.
Yes,
I hope all our participants are ready, and they'll be ready to get the.
Yes. Thank you so much for that session. It is actually a difficult task to cover all the non-GCT benign bone tumors in one small session. But this was more, as we know, as more for postgraduate residents and young orthopedic consultants to get an orientation in this field. And before we move on to the quiz, we'll just like to inform that now we are also ready for the next session, which will be on December the 10th, 5:30 to 7 p.m. And in continuation, that will be on giant cell tumor of bone, principles of management. And it will be moderated by Dr. Vineet Kurusinkal, consultant orthopedic oncologist from Royal Orthopedic Hospital in UK. And the chairman will be Dr. Subin Sugat, the leading orthopedic oncosurgeon from Kerala. As you know, now for the quiz, we need to download the Kahoot app. And what we'll do is we'll first play a practice quiz so that people who are just downloaded or playing it for the first time can get an idea about it.
So I hope all of our participants have downloaded the app.
Yes.
So they can just write in the chat box here, so that.
So this demo quiz is for that purpose, so that participants get an idea about it. So once you download the app, you get the instructions to join the game. Game pin is 6173321. So once you download the app, you have to join in with this game pin. This is the game pin for the demo quiz. And we'll just wait for the participants to download and join. Others are also welcome to join just to see what the fun is.
Panelists can also join.
Yes, why not? Why not? You won't get the prize, but
Won't get the prize.
you can definitely join.
I
So
think
this
people are writing pin something. Pin not.
What is the
visible.
pin? Yeah.
okay. Let me see. Maybe the screen share is not happening. Is it visible now? Is the pin visible?
Yes, it is. I think.
Yes.
Yes. The game pin is 6173321. I can see Dr. Deepak Garg has joined in, and someone named PKS. We'll just wait for a couple of minutes for others also to join in. Alazar from Ethiopia, and now we have more participants coming in. That's good.
Yeah,
This is the demo quiz. This is just to show how the game works, and so that you get an idea and orientation. So
I request everybody to join, please. It will be interesting.
So now we have around 30 to 35 participants in the Zoom meet. So we'll wait for at least half of them to join. Maybe we'll wait till 15 participants, and then we'll play the demo quiz. And once people get an idea of the demo, we'll move on to the main quiz. Okay, that's a good number. We have got half the participants. So we'll just play the demo quiz first. Okay, so let's start. So the first question of the demo quiz is, who is the Prime Minister of India? Is it red, Amit Shah? Is it blue, Draupadi Murmu? Is it yellow, Narendra Modi? Or is it green, Rajnath Singh?
So we have some time during which they have to answer.
Yes, so the last 10. So we have got 15 answers. Last 5 seconds to go for this first demo quiz question. 3, 2, 1. And the correct answer, as we know, is yellow, Narendra Modi. And 12 people have answered it correctly. That's 2 of them have got it wrong. No problem. It's a demo quiz that shows the scorecard. Salahuddin is leading. Very good. Now the second question and the last question of this demo quiz.
So one more thing, just I want to tell them how, although so many people answered, but how somebody got first.
Yes.
So it is about the time, how quickly you answer. That will give you higher points.
Exactly. So, you have to be correct and quick. So right. Which of the following is the national capital of India? Is it red, Mumbai? Is it blue, Kolkata? Is it yellow, New Delhi? Or is it green, Bangalore? And 16 people have answered it correctly, yellow, New Delhi. So that was about the demo quiz. So in the demo quiz, we have got MP as the first runner-up. Second runner-up, VPS has come first runner-up, and the winner is of the demo quiz is Salahuddin.
Right.
Great. So now that you have some idea about how the game is played, we'll move on to the actual quiz. Let's see. Okay, is the screen visible to the participants?
Yes, it is.
It is. Now the game pin is being generated. Now this is the actual quiz. Okay, this is the game pin of the actual quiz for today's session. 4459288. So you have to join again into this main quiz. As Dr. Vivek rightly said, getting the answer correct is not the only thing. You also have to be quick. There are 1,000 points for each question. The quicker you are, the more points you will get. We have got around 12 participants coming in. Again, same criteria. We'll wait for a minute. We'll wait till it joins up to maybe half the crowd. 13. Okay, great. 15. Just a minute more. Then we'll start. Sir, is the audio audible? You can hear the background with it.
Yeah, it's very well audible.
Okay, okay, chalo, very good. That builds up a bit of an excitement.
Yeah.
So, so we have got 15 participants. I just wait for a minute more before starting with the main game quiz.
Come on, guys. We are 30.
Okay, I think it has stopped at 15. So, with your permission, sir, I'll go ahead to start.
Yes, let's go ahead.
Yes, yes. So this is the main game quiz. Remember, as we played the demo quiz, you have to be correct and you have to be quick. So starting with the main quiz.
Yes.
The first question of this session quiz is as follows. Which of these is not a part of Benign classification for benign tumors? Is it red, latent? Is it blue, active? Is it yellow, aggressive? Or is it green, neoplastic? Which of the following is not a part of Benign classification of benign tumors? And we have got the answers. The correct answer is green, neoplastic. If Dr. Vivek can just elaborate on that.
Yes, so I think this was also a part of our discussion, that Benign classification of benign bone tumors comprises of one latent type, then active, and then aggressive type. So neoplastic is not a part of the classification. It is, we need to define the neoplastic.
Yes. So that was the first question. I hope people have got a hang of it. Now this is the scoreboard at the end of the first question. IRK is leading with 943 points. Come on, guys, buck up.
Great.
Now the second question, which of these is a part of McCune-Albright syndrome? Is it red, simple bone cyst? Is it blue, aneurysmal bone cyst? Is it yellow, enchondroma? Or is it green, fibrous dysplasia? Last 5 seconds to answer this question. McCune-Albright syndrome, simple bone cyst, aneurysmal bone cyst, enchondroma, or fibrous dysplasia. And 11 people have answered correctly. Fibrous dysplasia. Dr. Vivek, if you can just elaborate on the answer.
Yes, so we see McCune-Albright syndrome in association with polyostotic fibrous dysplasia, where normally the patients also have endocrinal abnormalities, precocious puberty. They have skin lesions and bone lesions like cafe-au-lait spots and fibrous dysplasia lesions.
Yes.
So fibrous dysplasia is the right answer.
Is the right answer. Very good. So I'm going to skip on the scoreboard for this and move on to the next question. This is a simple question, management of this lesion. There's a distal tibial lesion that you can see. What will be the management? Will it be red, observe? Will it be blue, biopsy? Will it be yellow, curettage? Or will it be green, excise this lesion? There's a distal, oh, fantastic. Oh, there's a varied list here. The correct answer is red, observe, and we'll have Dr. Vivek to explain why. So here is that photo.
Yes, so I need to explain it because I can see the participants were divided on different options like management. So see, first thing is, what are we suspecting looking at the lesion? So this looks like a well-defined lesion with a sclerotic boundary. And of course, the information given is not complete, like clinically how the patient is symptomatic. But we assume, like looking at this is the case of non-ossifying fibroma, which is mostly you observe it unless the patient is very symptomatic or it is involving more than 2/3 of the bone with pathological fracture. So that's why in NOF, the correct protocol is to be observe it first. And if it progresses to more than 2/3 of the bone with some aggressive features, we then only plan for any sort of intervention.
So the challenge here was to identify the lesion, and then once that is done, then we know that it's a touch me not lesion. So we observe it. So very good. We move on to the next question. The fourth question, identify the following lesion. There's an X-ray shared. It's a proximal humerus lesion. Is it A, aneurysmal bone cyst? Is it a blue, unicameral bone cyst? Is it yellow, chondromyxoid fibroma? Or is it green, fibrous dysplasia? This was discussed in the discussion. Come on, last 2 seconds, 1 second. And majority have got it correct. It's a unicameral bone cyst.
I think this is one of the classical X-ray of unicameral bone cyst where you see a fallen fragment sign. So this was a telltale. The picture speaks for itself.
Yes. So that was that. And moving on, we move on to the fifth question. We'll have a look at the scoreboard at the end of this question. Management options for this lesion in proximal tibia. Is it red, curopsy? Is it blue, curettage? Is it yellow, sclerosant injection? Or is it green, any of the above? There is a lesion in the proximal tibia. What will be your management option for this? Last 3 seconds, 2, 1. And oh, people, you have to be quick. The answer obviously is any of the above, and Dr. Vivek will tell you why.
Yes, so let us see, before the options, we need to identify what this lesion is. So you see a metadiaphyseal lesion, lytic zone, sclerotic boundaries, most likely a benign tumor, likely aneurysmal bone cyst. Now I assume aneurysmal bone cyst because all the 3 options also belongs to the same treatment aspect. So we can do even curopsy, we can do sclerotherapy, we can plan for curettage. So the correct option is any of the above. So another reminder, always read all the options before you tick it. So somebody must have just seen the first one and ticked it. Okay.
Yes, yes. And also,
guys, just to interrupt.
Yes, sir.
Personally, in this case, I would always say biopsy. But that option is not there because this is clearly a very aggressive looking, pathology in the proximal metaphysis of immature skeleton. So for me, an osteosarcoma, even a telangiectatic variant is clearly a part of the differential.
Agree.
So, assuming because this is a benign tumor session, we have to, sort of come to that conclusion. But otherwise, this is not a case where I would think about treatment first.
Agree. So this assumption is made on the because the information is obviously incomplete. We don't know the clinical status. We don't know the MRI, and as sir mentioned, biopsy. This is more just to highlight if this is a classical image of aneurysmal bone cyst, then what are the treatment options? But your point is taken, sir, that you will have to obviously go stepwise in assessment before jumping to the treatment. So moving on to the next question. At the end of 5 questions, let's see that scoreboard. Alazak from Ethiopia is leading, and there is MP and Rajendra. Come on, guys. You can buck up. You need to be fast, as we know, correct and quick. Let's move on to the 6th question. The following bone tumors, benign tumors, are known to show edema on MRI, except, is it red, fibrous cortical defect? Is it blue, chondroblastoma? Is it yellow, Langerhans cell histiocytosis? Or is it green, osteoid osteoma? Which of these 4 do not show edema on MRI? The varied answers here, and I think Dr. Vivek would have to explain this point.
Yes, so fibrous cortical defect is one of the lesions where we don't see much edema compared to the other ones. So it depends upon the histology, the type of inflammatory response that they induce leads to the edema in these situations. So this is the observation based on what we see in our day-to-day practice. Yes. So the correct answer is FCD.
Yes. So along with so any other lesions which show benign bone tumors which show edema on the MRI?
So we see commonly like your osteoid osteoma, chondroblastoma, giant cell tumors, ABC, all these show edema. And these are very commonly, once we start seeing the MRI, then you will remember. You need not mug up these things. But if we are dealing, you see every day, and you know that, okay, there is a lot of edema that we see.
Yes. Even some benign bone tumors, if they fracture, they also tend to show some edema. So I hope that point is clarified. Fibroscortical defect usually classically doesn't show an edema on MRI. So I'm going to skip the scoreboard for now and we move on to the next question. The following lesion is more likely to transform into what? Will it be red osteosarcoma? Will it be blue chondrosarcoma? Will it be yellow Ewing sarcoma? Or will it be green synovial sarcoma? The lesion shown transforms into what? Osteochondro Ewing synovial. And majority, in fact, everyone has almost answered it correctly. Dr. Vivek, if you can just reinforce that point.
Yeah, so this is osteochondroma that we see bony mass growing away from the epiphysis. And in rare situations, almost 5%, 1.5%, they may get a malignant transformation, which is mostly chondrosarcoma. But even in a variety of situations, there may be a transformation into osteosarcoma as well. So the correct answer is chondrosarcoma. But in rare situations, even osteosarcoma has been seen to develop in these lesions.
Yes.
Pratik,
yes, sir.
I would have worded it a bit differently though.
Okay.
This lesion can very rarely transform into a, rather than more likely to transform into a.
Understood. Yeah.
More, yes, sir. The wording has to be correct. Yes.
Yes.
Because it might give a wrong message. Of course, it's just a quiz, but still.
Agree, sir. Agree. Yeah. It was meant to say ki out of the 4 options, what is it likely
I got
to
that.
transform?
I got that. But those who are not initiated into oncology,
agree.
May read it a bit differently.
Yes. Thank you for that clarifying point, sir. Hope the participants also keep this in mind. And moving on to the next question, the 8th question of the quiz. This lesion, if you can see, there's an X-ray and MRI, is a classical presentation of what? Is it red aneurysmal bone cyst? Is it blue chondroblastoma? Is it yellow eosinophilic granuloma? Or is it green osteoid osteoma? You can see a lesion in the proximal head of the femur. And again, there is a divide in opinion. Vivek sir, if you can just clarify that.
If we look at the X-ray and the MRI, we see a lytic lesion in the epiphysis of femur, in the head of the femur. So, the epiphyseal lesion, if we look at it, the chondroblastoma is the most appropriate answer. And also, comparing to the last question where we saw edema, you can see there is a lot of edema in the femoral neck. So the correct answer is chondroblastoma. Osteoidostoma, it's a cortical-based lesion. Eosinophilic granuloma is a pure lytic lesion. ABC is mostly a expansile lytic lesion in the metadiaphyseal region of the bone.
Yeah. So I think people are just getting a bit slow. Come on, guys. Last 2 questions. We'll just
Things
have a look.
Can change. Come on. Things can change.
Alazar has dropped down to 3rd. Divesh has moved up. Our panelist is in the top 3. And MP is also in the top. So let's see, last 2 questions. You guys, there are a lot of points at stake. Things can change. Buck up. Coming to the second last question of this quiz. Multiple of these lesions constitute what? Is it red neurofibromatosis? Is it blue multiple hereditary exostosis? Is it yellow Ollier disease? Or is it green familial adenomatous polyposis? The lesion which is shown, it is involving the proximal phalanx. And we have got an answer, yellow Ollier disease.
Yes, so I think this is a classical, like we had discussed the enchondroma case. So especially in phalanx. And once you see multiple lesions like this is Ollier's. Sometimes it is associated with myxomas or soft tissue vascular neoplasm. Then it is called Maffucci syndrome.
Yes. So Ollier's disease, multiple enchondromatosis. So the last scoreboard will be a suspense. We'll quickly move on to the next and the final question of this quiz. This lesion shows the following sign on radiology. The lesion which is shown, the spinal lesion, does it show red corduroy sign? Does it show blue accordion sign? Yellow Coca-Cola bottle sign? Or is it green Mercedes-Benz sign? 3, 2, 1. And the correct answer, as some of you have guessed, is corduroy sign. We'll have Dr. Vivek explain as to why that is.
So let us see, signs come secondary. First, we need to identify what lesion is it. It is, so we can see a hyperintense lesion in the vertebral body. And so this is a hemangioma. And what you see on the hemangioma is a corduroy sign on sagittal sections. And you see verticals like strippings type on radiology. And if you see a cut section, that sign is, this is also seen as a polka dot sign. So hemangioma with corduroy sign is the right answer.
Thank you, sir. And that is the end of the quiz. Let us now look at the winner of this.
I'm also eager to see.
So on the third position, we have got Mr. MP.
So we know that, let us know the name also.
Yes. And in
Doctor.
second position, we have Rajendra. And in first position, we have Alazar. Oh, he made a comeback. Congratulations, Mr. Alazar.
Congrats. So MP, we would like to know the full form.
Yes. If we can, if Mr. Alazar can hear us, if you can just switch on his video and share how was the session in total and how was the quiz also.
Yes. Hello, sirs.
Hi.
Hi.
Yeah, I'm Alazar from Ethiopia. The session was excellent and the quizzes were a little bit challenging, but I did it. Thank you very much.
Thank you for joining from Ethiopia. I hope you join us for subsequent sessions along with your colleagues there.
Pratik.
Yes.
And Vivek.
Yes, sir.
Sorry to interrupt for a moment.
Yes, sir. Yes.
This corduroy sign.
Yeah.
Is it described on the MRI or on X-ray or on CT?
It's mainly on the CT scan and X-ray, sir. That we see.
Yeah. So your image was an MRI.
So
yes,
it was indirect question, sir.
Huh?
It was
I identify the lesion on the MRI, but the sign is not of MRI. As sir mentioned, it is seen on CT scans.
Correct.
Yeah.
Because I didn't see any of those corduroy signs in this one. It was uniform. It was homogeneous.
Yes. We didn't want to show that specific classical sign because then quiz
No,
would have.
that is not being fair.
Quiz would have been very easy.
That is not being
This
fair
was the tiebreaker sort of a question.
Okay. This was the gold
Differentiator.
medal question.
Gold medal question.
Okay.
But yeah, so that
honestly, congratulations to who was that?
Alazar.
Yes, congratulations for acing this one.
Yes.
But I really am curious about those who got the first two test questions wrong.
Sir, we have actually got a lot of participants who are not from India.
That's what I assume. I hope
yeah.
that was my next line. I hope that person is not from India.
Yes. And in fact, I'm surprised to see a participant from Ethiopia also, and that is in a way good because that shows that it has reached.
That's fantastic.
Yes.
You're so welcome here.
Yes. And I hope there are more participants because in previous sessions we have had winners from Nepal also.
Great.
Yeah.
Excellent. Great. I'm so pleased with this and your quiz was fantastic.
Yes. And there is a hello from Malaysia in the chat box.
Oh, so nice. Most welcome.
Yes.
So there are
few of them. Yeah, they are out together, I guess.
You're most welcome, and please join us in subsequent sessions as well.
Yeah.
I hope more participants from India also join, and I think we need to spread the word more aggressively and rigorously. So maybe for the December session, we'll have a slightly different strategy. Maybe start pushing for the advertisement a bit early. But otherwise, a great session, sir. Dr. Vivek, Dr. Chetan.
Very nice.
Thank you. Yeah,
really fun.
really enjoyed it.
But what will be the price thing? I mean,
So
is
it is cash money.
Okay.
So 2,500 for the
in
first.
dollars, I hope.
So budget is a bit restricted. So for now it is Indian national rupees.
Okay. No, but you may have to convert into dollars because it
Yes,
has
so
to go to
that we'll
Ethiopia.
have to sort out the logistics now. We'll have to get in touch with
Otherwise, it will be useless currency like Zimbabwe.
So
No problem.
Intas Pharmacy is kind of sponsoring this. So we'll have to get in touch with them as to ki dollars mein kaise karna hai.
Correct.
I can take it on behalf of Al-Azhar. No problem.
So yeah, so now I think we can then conclude the session. Please join us for the December session, and hopefully we'll have more participants also by that time.
Yes.
Thank you, everyone.
Thank you.
Thank you, guys. Bye-bye.
We'll be getting in touch with the participants for their bank details, the quiz winners. So don't worry. And hope to see you soon.